It looks like we have some folks coming in today. Thank you guys so much for joining us today. My name is October Boyles. I'm the Chief Clinical Officer with IkeNotes, and you are attending the behavioral telehealth liability considerations today. So we have an excellent speaker today. Her name is Cheryl Gregory. Cheryl's been a nurse since 1997, and she's worked in a variety of settings like the emergency department, ICU, cath lab, and she has her bachelor's degree of nursing from the University of Central Florida and a master's certification in nursing education. And she's also a graduate of Barry University School of Law, where she founded the Student Health Law Association, and she was part of a national award-winning trial team. And she also worked for or interned for the state attorney's office as well as several medical malpractice attorneys. She's well versed in healthcare liability, both from the plaintiff and the defendant's perspective. And Cheryl's enrolled currently in Washington State University PhD in Nursing Research Program. So, and together with the DNP, she has now co-founded the Healthcare Advisory Institute. And Cheryl, thank you so much for joining us today. We're so glad to have you, and thank you for all the attendees as well.
Thank you for having me, October. I appreciate it. Are we going to wait for a few more minutes until make sure everybody else attends, or
we are? Yeah, and it's looking like we already have a lot. We actually have a really good amount of people in here so far. This is great. The attendance for this, we had over 275 folks registered for this today. So this has been really good, and I actually see some really familiar faces in there. So it's great. Hello, everyone. It's great to see you. So we have a lot of current IkeNotes customers already I could see in there. So great seeing you guys. Fantastic. So I'll let you go ahead and take it away.
Fantastic. Thank you for that introduction. And I really appreciate everyone coming and giving me their time. October had mentioned the Healthcare Advisory Institute. And so we do a lot of consulting. We do crisis management, risk, quality, compliance, and regulatory remediation. And we're developing right now an interdisciplinary telehealth certification. So many of them that you'll see out there, or actually there's only a few that are out there right now, are provider specific or nurse specific and are also not accredited. And so this one is going to be an interdisciplinary one and accredited. So stay tuned for that. If you're interested, you can email me later after this. And I just wanted to start out with a disclaimer. No one going to law school will ever put a presentation together without doing a disclaimer. So no information contained herein should be construed as legal advice. Listeners are encouraged to seek independent legal counsel if you have any legal guidance questions after this is over with. So this is informational to provide you a framework so you can begin identifying any issues or opportunities as you build or continue with your telehealth program that you might have. So there's been a recent surge in telehealth appointments, and it's creating quite a preference for virtual care. Over 90% of people who've had a telehealth appointment say that they're more likely to seek more telehealth appointments instead of being in person in the future. And nearly half of those people said that they picked their provider based on the fact that they did have a telehealth option instead of just a brick and mortar clinic. So that's kind of an encouraging for you. And further, based on the fact that I think all of our audience is mostly behavioral health, nearly half of those people said that are seeking medical treatment for behavioral health issues. So that's pretty reassuring. So let's get to the slides here. So what is telehealth and telemedicine? You're going to see these terms batted around kind of simultaneously, and there is a little bit of a nuanced difference. So telemedicine is remote and clinic specific, whereas telehealth is kind of a broader umbrella that can encompass things such as education, getting CEUs, CMEs, and those kinds of things. And so I bring this up because each type of telehealth does still require the same legal and risk considerations. So you think typically of telehealth or telemedicine as maybe a FaceTime type of situation, right? Where the patient is at home, they're on their cell phone, or they're looking into their computer, and then the provider is at a facility offsite somewhere else. But you still have to look at what the security and privacy considerations are as far as remote patient monitoring. So there's different subtypes underneath that, and the reason that you need to understand this is still those liabilities are going to attach. So you'll hear different terms, asynchronous, synchronous. So the synchronous is that one that most of us think about, right? We're FaceTime, it's real-time interaction. I say something, my provider asks me something, we're back and forth interfacing. Whereas asynchronous is called store and forward. So it's the radiologist sending my x-rays of my shoulder to my provider, my nurse practitioner, streamlining any media, any other wireless communication. And then the remote patient monitoring, that could be anything such as a Holter monitor to check for a patient's cardiac arrhythmias, blood sugar monitoring, respiratory type of things, your Fitbits and those kinds of things. So just remember that those do still carry liability issues. So what should we be concerned with as far as practices? When you're talking about this, I'm going to break it down into organizations, providers, and then patients. So let's talk about those for a little bit. So some of the organizational concerns, we're going to look at insurance coverage, privacy, credentialing, policies, laws, and technology, and a few other things. I was speaking with a colleague of mine from back in law school days, and she is a international cybersecurity broker, and she has generously offered that any attendees here, if you want to email me, she's happy to review all of your insurance policies to make sure that based on your corporate structure and what type of telehealth you're doing, she can identify some vulnerabilities for you. So if you'd like to do that, we'd be more than happy to do that free of charge. But be sure to speak with your insurance carrier as you're looking at doing telehealth, because cybersecurity is in and of itself a separate entity from what you might already have right now. I'm hoping that every one of you has some professional liability, or what they call medical malpractice insurance. Errors and omissions, insurance policies are huge, because you want to make sure that your directors and your officers and everyone, that you've got a corporate formalized structure by which you're taking care of identifying early and then making yourselves internally accountable. October, did you want to speak to that at all? Or are you going to wait until the end?
Oh, sure. Well, one of the things I know, and I will wait to talk about telehealth
Okay, sure.
within IkeNotes till the end. But one of the things is that I think is really important about our telehealth is that we're not using another platform. You talked a lot about security and concerns with that. We know that Zoom got bombed recently, right? So there's a lot of concerns about privacy. And so with IkeNotes, we knew that, and we created our own telehealth feature that's proprietary. It's not an app, so it's not like someone can hack into it. And so we made sure that from the security features, we were covered on that, because we know how important it is that people not be able to hack into these things. And right now, it's a really scary world out there. It's kind of cyber wars that people are very unaware of unless you work in the tech industry. And so that's one thing that we're constantly striving with IkeNotes to make sure that we don't have those security issues. And I need to really knock on something wood of some kind, but so far we have not been afflicted like some of our other companies and competitors have been. So.
Absolutely. And you bring up a good point with the privacy. Be sure that your telehealth platform and all your devices and all of your related technology remains HIPAA and high-tech compliant, along with all other relevant regulations, including your license boards. And one of the things that a lot of people often overlook is be sure that your third-party vendors know that you're going to be utilizing the telehealth services, and receive assurance from them in writing that they have measures in place, that they do periodic reviews and audits, and that they provide you with those results. And make sure that your business associate agreement and your confidentiality agreements also go to that, so that you can hold their feet to the fire and keep them accountable. Privacy and vendors, you need to make sure that you're using due diligence, and that's one of the ways in which you can show if you get audited, if you get fined, if you have denials of claims, you can show that that's one way you're doing due diligence, is that you've communicated with your third-party vendors that you're going to do that. And I do suggest that if you haven't started the platform, that every one of you does the failure mode and effectiveness analysis on it so that you can start to identify and map out your what if situation so that you can kind of have some countermeasures for that. And they've talked about the auditing and reports from third-party vendors. And what they have found right now, the benchmark that everyone is typically using, is that they recommend quarterly reports when you first start out. So if you're just about to start launching your telehealth, I would recommend that when you speak with your third-party vendors or your internal IT department, that at least on a quarterly basis, you're starting to look at what kind of issues are going wrong. Do we have any integrity breaches or any opportunities that we need to kind of shore up? And then you can taper from there based on what your responses are. So let's talk a little bit about credentialing. So for those of you that are Joint Commission, I don't know how many of you are Joint Commission accredited. I spoke with a friend of mine who's a surveyor right now and told him that I was doing this webinar and asked him if he had any specific recommendations based on telehealth. And he said that HRM 01.02.01 includes credentialing requirements for all staff who provide care, right? And that is a wide umbrella. So be sure it's not just the people that are getting a paycheck from you. These are part-time people, these are contracted employees, volunteers, and students. So be aware of that. Anybody who's employed, and all of those people I just listed are considered employed for this specific survey point, or licensed independent practitioners, they're all considered staff. And so the comprehensive accreditation manual for behavioral health does not specifically require credentials during a disaster. So therefore, you would want to use the HRM 01.02.01 as your coverage, as your baseline, as your starting off point. So let's talk a little bit about licensed independent practitioners, because we just mentioned that just a second ago. Currently credentialed LIPs do not have to have extra credentialing or privileges specific to telehealth. But if you bring on anyone that's new or out of state, the credentialing and the privileging does need to specifically outline that. So there are no requirements right now that I am aware of that telehealth be delineated as a separate privilege, but it is a very good practice for you to have that and examine that. So will you be bringing in newer temporary providers? Does your state allow for credentialing by proxy in case you have a provider that is out of state that's going to be providing services for you? So that's a thing that you need to be considering. And also be mindful of what can be delegated within the telehealth arena. So if you have multi-tier providers and you're going to be delegating any of your services, you need to make sure that you're looking at those state boards and that who you have delegated to, it's within their scope of practice. So I mentioned a few minutes ago about the term due diligence. You're required to keep up with what the latest changes are. And right now they are changing at rocket speed. COVID-19, of course, has just turned everybody on its ear, and we're pivoting and turning and trying to respond as nimbly as we possibly can. So a lot of the states are really trying to work together with the state boards in order to be able to facilitate getting care to as many people as they possibly can. So one way to shield your organization is to provide regular education to all of your staff and your administrative personnel, as well as your board members, education and documentation, and have that communication be timely. So make sure that you leave yourself a paper trail and you have an infrastructure by which everyone is getting the information as quickly as possible. So then you're going to want to talk about what your policies are going to say internally. You know, we all need a standard operating procedure, right? And especially when we're doing something new like this, it's such a cumbersome process. What type of patients are you going to see or not see? You need to have that up front, because there are certainly going to be people that this is not going to be appropriate for, right? You want to make sure that you have it in writing and that your provider is aware. Create yourself an exclusionary list and maintain that. Have that be as current as possible. That needs to be a living document that continues to evolve based on what you are finding. Are you going to want to see a patient that's hallucinating and has fear of technology? That's probably not going to be the best way to take care of that patient, right? So don't just look at their diagnoses, because then you're going to shortchange yourself and the patient. Sometimes it's going to be important to know what the patient's presenting symptoms are. If they feel like technology is, they've got a paranoia against technology, that's a symptom, but that may not necessarily show up on a high level diagnostic list. So develop yourself an algorithm-assisted diagnostic tool. You want to look at patient data collection and analytics. And then telemedicine, it may be able to minimize your errors and improve outcomes by doing that. So another thing, as far as the providers are concerned, I wanted to bring that up really quickly, is decreasing clutter. And in your policy, make sure that you speak to grooming expectations with providers. And this is the silliest thing to have to bring up, but we'll talk a little bit later about the impression that you're making on the patient, and that's one of the things that kind of helps set the professional tone. So you want to outline by which methods the telehealth is going to be conducted and which ones are going to be prohibited or discouraged. We have had my colleague, the insurance broker, has been telling me about all of the claims that are starting to brew up in her within her wheelhouse. And she had a provider that was using his smartphone in a public area to conduct a telehealth session. And so, the patient was not getting any privacy. The provider, that was just absolutely unprofessional and inappropriate. And when we went back and looked at the policies, there wasn't anything in the internal policies that prohibited the provider from doing so. So make sure that you have a very bright line as to where these providers can be, what mechanisms everyone can be using, what locale will be used by both the patient and provider. Providers must be in a facility. They cannot be at home. They cannot be at the bus stop. They can't be out at, having lunch with friends. The provider does need to be in the facility from a liability standpoint and from a reimbursement standpoint. And be mindful of EMTALA for those of you that would have to be dealing with that. Have a plan in place should the patient present with an emergency. You need to have a strong follow-up plan, and then you need to make sure that that plan is being followed. So make sure that you have an accountability process for that. As far as the laws are concerned, every single state varies as to where the patient and provider need to be located. If the provider can prescribe, verification of the location, etc. There have been several cases that have come before the court that haven't yet been decided just yet, but they're kind of brewing right now, that are arguing venue from where the provider is located. And so that seems to be the consensus, that treatment actually, as far as the court cases are concerned right now, it looks like what's making some traction is that treatment is where the patient is, not where the provider is. So just think of this as a patient-centered type of thing, and then you'll understand where venue is. But be aware of the applicable state laws, and I recommend doing a crosswalk between what the federal government is saying, CMS, Medicare, your state, your county, and any of your payer sources. Do a crosswalk and then narrowly tailor your protocols so that you can adhere to each and every one of those, because it's very, very easy to make a misstep on that. And October mentioned technology a few minutes ago, and IkeNotes has done a fantastic job fortifying their process, making sure they don't have any weak links. People engaged in telehealth need to ensure that their software and their equipment used to perform the telemedicine complies obviously with HIPAA, and your applicable state patient privacy laws. And HIPAA is not the only show in town when it comes to regulating the patient and maintaining their privacy and integrity. There's at least 15 I can think of just in the state of California alone that need to be adhered to. So not all interactive programs satisfy this requirement. So be sure you know what the limitations are. And keep an updated maintenance log. That is going to be one of the key defense strategies that you can use to mitigate risk and to show yourself in the most favorable light if you get surveyed, if you get audited with the Office of Inspector General. Keep a maintenance log. Malfunctioning equipment leads to potential workarounds, right? This is not anything new to anybody listening here. And there could be system and practice vulnerabilities, right? So you want to make sure that you have firewalls and all the appropriate safeguards put in place. The latest requirement, and correct me if I'm wrong, October, but it needs to be 128-bit level encryption when you're transmitting data through the telehealth, telemedicine ecosystem. Data transmitted and held in or on such a platform needs to have functional auditing, archiving, and backup capabilities. So be sure that you have all three of those in place. And as far as billing is concerned, most clearinghouses are requiring you to use a certain modifier to indicate that you're using telehealth or telemedicine, and whether it's hub and spoke or whether it's direct to consumer. So I believe the asynchronous modifier is GQ and the synchronous one is GT, but double check that before with your clearinghouse. So let's see here. So as far as we've talked about that. We've talked about privacy and credentialing. Does anybody have any questions on that so far, or should I keep going?
Cheryl, I think a question that people were asking is a lot of folks were wanting to specify what you meant by facility. It said, do you mean that we cannot work from a home office, which is listed as an administrative office for insurance policies? I think a lot of people had a question about, can our facility mean our home office? Is that?
It should be, and all of the states are so different. It'd be really tough to say. But look at what your state policies are saying to you, and what the Medical Practice Act has been saying. Depending on what provider level you are, typically it does need to be part of the organizational corporate structure. I can give you that as enough of an umbrella. Is that? I don't want to get too much more specific.
Sure, no, that's good.
But it does need to, whatever facility it is, it needs to fall underneath the corporate umbrella.
Sure, that's good.
We can take those kinds of specific state-specific questions. If anybody wants to email me, I can walk them through that as well. So not a worry. So we're going to talk a little bit about provider concerns. Some of the same things still need to take effect, but some of these have a little bit higher level of importance now that we're talking about telehealth. Obviously, you need to identify yourself, but did you know that failing to provide verification of who you are could be construed as misconduct? So make sure that you either have a name tag on, you've said it out loud. I have also seen that in some telehealth situations. I had my very first telehealth visit about a month and a half ago, and the nurse practitioner had her name on a kind of on a ribbon underneath the screen, so I could see that the whole entire time, which was really nice. And then you need to identify the patient. You need to verify that they are who they are. I know that when I had my visit, I had to show my driver's license up to the camera. Have them confirm their location, being state specific. I am in Richland, Washington, and I know that there are a few states that are playing around with the idea of having the patient ping their location to the provider so that they can verify that. You want to make sure that both the provider and the patients are in states that you are covered with, and that you understand what those state laws, so that you're not practicing outside your scope of practice. And again, as I said earlier, it's the location of the patient that defines where care has been delivered, and that's the jurisdiction of applicable regulations. So you need to understand where they are to protect them and to protect you. So let's talk about obtaining consent. And so this is going to be twofold. So this is going to be a little bit extra than what you would do in person. You need to create a consent to the telehealth process itself, not just treatment, not just consent to treatment. It needs to be consent to telehealth. You need to have a form for that. And this is going to be different than the consent to treat. Like I said, make sure that you know your state's requirements as who can obtain consent. So there are some states that allow the nurse on the front end to do that. Some have the provider right before the face-to-face begins obtain that. So know what mechanism and who can obtain the consent and when in that process the consent needs to be obtained. I think right now there are 38 states in the District of Columbia that require practitioners to obtain the telemedicine consent from the patient before the electronic session starts. And so while it's not exactly a consent to treat document, telemedicine consent does provide evidence in your note that the patient agreed, right? I understand, yes, I'm willing and agreeable to go ahead and engage in this telehealth process and be treated by a distant provider via telemedicine. So if you want to check your state Medicaid and medical boards for any language, a lot of times they have some verbiage that you could just cut and paste and have that be specific to your area. Establishing provider-patient relationships. So that's a really important one as well, right? Because you need to satisfy each of these criteria in order to be able to check that box. Right now, this is the gold standard here. And again, that's a moving target, but this is so far the gold standard. Having a face-to-face history, which you can obtain by patient in real time or using audio or visual and any interactive electronic means. You need to have received or have access to the patient's health records, including the name and the address of the patient's primary care provider, right? Because we need to have another link in the chain as far as making sure that they're getting their follow-up care. You need to be able to do a physical exam that's appropriate to the principal complaint that they've made to be able to make a diagnostic and therapeutic plan with the patient. You need to discuss the diagnosis or treatment with the patient. You need to discuss the availability of appropriate follow-up care with them and provide the patient with the telehealth provider's license number and contact information. A lot of times that's one of the things that we're seeing that people are forgetting to do, because once you've disconnected the session, a lot of times the patient's kind of scrambling to figure out a way to follow up with you if they've got a quick question or they need to add to the conversation. So dictate or prepare proper medical documentation of the visit. That's an obvious one. And adhere to all the state medical record retention laws. And if you know that the patient is in Florida and you're in California, you need to understand both of the laws of retention in both of those states so that you're not destroying any information prematurely. So as far as the documentation is concerned, if you fail to meet the medical record standard, that's punishable, right, as a medical misconduct case. Medical records have to reflect the appropriate evaluation of the presenting symptoms. So if you early on see that this is kind of outside the scope of this mechanism of telehealth and telemedicine, you need to have a plan B in place. It needs to be formal so that you haven't missed the ball in any way. Now, personal communication with the patient that's not part of the medical record. Let's say I've texted my nurse practitioner prior to my telehealth meeting with them and I've sent them a picture of my wound or what have you. It's not necessarily part of our telehealth session, but that communication needs to go somewhere, right? So you need to be able to have a place, a mechanism or a place to store those that's outside of the medical record, but is a supplement to that session. One of the other areas that we've really seen people dropping the ball, or opportunities to improve, I should say, is be sure you have a written protocol to handle and track your referrals and follow-ups, because we're seeing that we're telling people they need to follow up with XYZ or do this, that, and the other and return to us, and they're not coming back. And especially in telehealth, when patients are homicidal or suicidal, we really need to make sure that we're closing that loop so that everyone stays safe. So we're seeing a lot of claims activity for failure to follow up. So be sure to have a mechanism for that. The other thing you need to think about is evaluating, treating, and prescribing. Prescribing laws are so widely varied based on location and what substance you're going to be prescribing or considering prescribing. Some states have very strict laws regarding who can prescribe medication through telemedicine, so it's really important that you understand what laws are applicable where you're practicing and where your patient is. Some states have completely banned prescribing through telemedicine completely. They just don't even want to open up that bag of worms, and then some others allow it if you've already got an established patient-provider relationship. So now we're going to talk a little bit about licensure portability, right? Because you have a license in California and you've got all these other patients in different places, and it's important to understand how to be more nimble about that so that we can broaden our scope and see as many patients as we can. I'll give you a little example as to why this is kind of important. In 2007, there was a Colorado licensed psychiatrist, and he was criminally charged with practicing medicine without a license in California. His name was Dr. Hegeseth. He prescribed medication over the internet to a patient in California who later committed suicide. After Dr. Hegeseth challenged the court's jurisdiction, and that failed, he pled guilty and was sentenced to 9 months in prison. So the case kind of demonstrates how complex telemedicine is from a legal perspective and the importance of understanding and giving physicians and providers education regarding licensure requirements for practicing telemedicine across state lines. So one of the ways that the federal government and the medical boards and NP boards and social worker boards have decided to tackle this idea is to have compact licensure agreements. So what it basically is in kind of a nutshell, it's a voluntary, expedited, streamlined pathway for licensure for qualified providers who want to practice in multiple states, right? So it's a legal agreement among participating states that allow them to work closely together to address issues that are of mutual concern, right? So hundreds of compacts exist in the US, and they've helped all the states address everything from shared water to transportation uses, that kind of thing. So it's basically, if you think about it, it's an informational repository and exchange between states. So in the case of interstate medical licensure, it's an agreement that allows states to work together to significantly streamline the licensing process for physicians and providers, DOs included, who want to practice in different areas. And in recent years, the growth of telemedicine and other technologies created new opportunities, right, to increase access to healthcare for patients, mostly in the underserved and rural areas, and allow them to have easier access and connectivity with medical experts, right, because those are the ones that are typically underserved. So physicians are increasingly able to use the telemedicine platform and practice in a lot of states. And just to give you a quick snapshot, even though they've been around since 2013, this compact, in 2018, there were 654 applications to go across state lines, 654. And so as of April of this year, there's nearly 3,000. So you can see that it's really bubbling up. It's starting to become one of the burgeoning areas of providing healthcare. So in an effort to maximize the potential of using the new healthcare advances, state medical boards, again in 2013, started to discuss how can we facilitate getting this put in place. So the idea was embraced. A lot of diverse state boards and whatnot all got together, and then over the few years, they kind of put some groundwork together, and they created this licensure compact. So with the assistance of the federal state of the medical boards, a group of state medical board executives, administrators, attorneys, they all drafted this compact. And then it was publicly introduced in 2014. And then some state legislatures kind of started adopting it. And then in early 2017, it became fully operational. So it's not really all that old. And about 80% of US physicians meet the criteria for getting licensure, which is encouraging, so that they're hoping to open that and broaden that a little bit. So the compact states that the qualifications and outlines processes for providers to apply and receive licenses. The compact establishes and defines the roles of the Compact Licensure Commission, which is a governing body that administers the compact, and it sets limits on what the commission can do. So in order to become eligible to be a compact licensed provider, you have to hold a full unrestricted medical license or provider license in the state. in a state that's a compact member, and that's called your state of principal license, SPL, if you ever see that. And then you at least have to have one of these 4 criteria. Your primary residence is in the state of principal license, or at least 25% of your practice occurs in SPL, or your employer is located in that state, or you use the SPL as your state of residence for federal income tax purposes. So any 4 of those would allow you to have criteria for the SPL. So in order to remain active within the compact, you have to maintain your SPL all the time. You can redesignate later if you decide that you want to relocate elsewhere to another place after you've received your initial qualification, as long as that state is also participating in the compact state. In addition to having the basic SPL status, there's several general eligibility requirements that you need to meet. You have to have graduated from an accredited medical school or a school listed in the International Medical Education Directory. You have to successfully have completed the ACGME, have passed each component of the US MLE or Complex USA. You have to have hold a current specialty certification or time-limited certification via ABMS, the American Board of Medical Specialties, or conversely, the American Osteopathic Association Bureau of Osteopathic Specialists, mouthful there. And you cannot have any history of disciplinary action towards your medical license, nor have any criminal history, nor have any history of controlled substance action towards your medical license, nor currently be under investigation. And it's the under investigation and no disciplinary action that makes up the bulk of the nearly 20% of the people who are ineligible for compact licensure. So the process is pretty easy as far as getting your compact licensure. You confirm your eligibility based on all the criteria we just mentioned. You start the online process. You can do it by paper, but online is much, much quicker. You choose your SPL. That's going to be on your initial application. And then the state of licensure, the state of principal license is going to be the entity responsible for conducting the primary source verification of all of the credentials and education. And then they're going to verify eligibility. And then what they're going to do is issue you a letter of qualification or notify the commission that you're ineligible. Then you'll pay $700 and complete the form. And then you need to get your fingerprints done. And then there's a criminal background check and a national criminal background check. And that needs to be done within 60 days of starting your application process. And then between 20 and 26 days or so, you'll get the application's going to be received, and then you should be getting your LOQ. I went back to look. Typically, there are heavy times that they're administering and processing these are August and December. So if you're putting in your application around that time, expect to see a little bit of a delay because there seems to be a spike in that time for whatever reason. And then you'll either get your letter saying that you qualify, or the commission will notify you that you don't qualify for it. Then you'll pay your state license fees, and then you'll sign documents using DocuSign, and then the medical boards of compact states will issue you your license within just a few days, actually. It's a pretty quick process. And then after you get your license, the compact doesn't require you to maintain or participate in a maintenance of certificate process. So as long as you have a certification, board certification, prior to the eligibility, you don't need to maintain that once you've been deemed eligible. So if you go onto the website, and I'll give that to you if you want to email me, I can send it to you. There's a website that is specific, and it will show the US map, and you can go on there and click it. And then it does a crosswalk of all the regulatory requirements to receive state licensure through the compact. So if any participating board takes action against the provider who has a compact license, all the boards within the compact are notified and authorized to take similar action through their regulatory complaint process. So it's a pretty quick domino effect, and I've seen it happen. It's at a staggering pace. That's one of the only things that I've seen go really, really quickly. So that is the compact in a little bit of a nutshell. So let's a little technical difficulty here. There we go. We've talked about identifying the patient. We've talked about consent being twofold, not just consent to treatment, but consent to the format of the treatment. We've talked about provider and patient relationships, having the appropriate documentation pieces in place. We've talked about what sufficient documentation looks like, making sure that you're evaluating for the patient's presenting symptoms. And we've talked about the importance of having written protocols for handling and tracking referrals, because again, that is just one of the biggest problems that we're seeing when we go in and do organizational risk assessments on providers and organizations that are starting telehealth. That's one of the big areas of opportunity. And then prescribing, just know your laws, know the laws of where you're at and where your patient is. Licensure portability, we've talked about that. So let's get to the patient. Let's talk about what the patient's aspect is here. A strong physician-patient or provider-patient relationship improves care and wards off malpractice. I'm going to say that a couple of more times as we go through here. I used to be the corporate compliance and claims director for a 4-hospital enterprise. It was an integrated delivery network, over 10,000 employees, over 500 providers. I was taking care of all the medical malpractice claims for that institution. And I will tell you, the number one trigger for medical malpractice claims is that the patient is dissatisfied with their interaction with the provider. So that is the sentinel trigger. There was a sentinel study that found that physicians that didn't have medical malpractice claims employed the following best practices. They communicated with their patient. They oriented the patient about what the visit would entail. And that's especially true in telehealth. You know, they don't know what they're expecting. And especially in mental health, they may have some anxiety that decreases their ability to take in that information, right? So giving them a little bit of a roadmap. Hello, Ms. Gregory, I'm your nurse practitioner. This is what we're going to be doing today. We're going to talk about, and then just kind of map out that process for them. That gives them an idea of what to be expecting. That and the no malpractice providers also solicited opinions and concerns. They verified patient understanding, and they spent more time during the office visit. They didn't give them the bum's rush. So interacting with them, engaging with them, asking them questions, building it as a partnership rather than the patient is the victim of the care has always been best practice. A third of medical malpractice litigation, they say, was related to communication problems manifested by the provider appearing anywhere from being attentive to being discourteous to providing not enough information for the patient to feel like they're making an informed decision. Research shows that a positive rapport with patients, largely based on quality communications, influences whether a patient's going to make a malpractice claim or not. It's just that simple. So the takeaway from this for administrators and everyone in the support roles, provide robust ongoing support to your provider throughout the rollout and beyond. Make sure your provider doesn't come across as frustrated with the technology, because then that sets that tone right away. And once you sour it, it's a lot harder to salvage that experience. When I had my experience about a month ago, I was excited about doing the telehealth because I knew I was doing this webinar, and so I was asking her questions. And the nurse practitioner kind of went on a tirade about how frustrated she was with her system and the IT people and the this, that, and the other. And you know, that's the first trigger right there. That just sets the tone that regardless of if she was rude to me, now I wonder, are there vulnerabilities? Now is my care being shortchanged because she, you know, the nurse practitioner didn't know what she was doing or wasn't using it to its full power. So be sure that you have robust ongoing support for all of your providers. That's going to be huge in protecting your organization. So tools to address patient satisfaction. I know this doesn't sound like a legal thing, but it really does help prevent and mitigate those. Employ patient-centered approach. Solicit their response, ask them for their ideas, ask them their expectations, ask what their preferred pronouns are, right? There's a lot of talk right now in the LGBTQIA community, people who are non-binary. Please ask them what their pronouns are. That really shows that you're doing your due diligence and you're meeting the patient where they are. And use the language that the family or the patient can understand, taking into account their health literacy, whether they have limited English proficiency, and even their culture, because sometimes some cultures are kind of frown upon asking questions because it seems like it might be confrontational rather than it just being a misunderstanding or needing a little bit more elaboration. Personalize the information rather than just giving a canned speech to them, and develop a partnership like we talked about. They're not the victims of the care, they're part of that team, right? And review the patient's preference for information. Maybe they want it all rattled out up front, and then we're going to kind of untangle it as we talk. Maybe they want one idea introduced at a time and then continue to talk after that. So that's always been helpful. Present information and help the decision makers reflect on the impact of the various treatment options that they've got, especially taking into account their lifestyle and their values, right? If you're talking to somebody about weight management and this, that, and the other, and they're vegan, you're not going to bring up a lot of meat sources, as a protein recommendation, those kinds of things. And agree on an action plan and complete arrangements for the follow-up. Make sure that they know the address or the phone number of where it is that they're going to be going. So make sure that the patient repeats back what they understood, right? Make sure that they understood and processed appropriately what it is that you've said, what everyone has talked about. Clarify information and plans as you need to, and then document the agreement and the actions taken in any follow-up, because that right there has been a key in more claims than I can begin to tell you. The patient and I developed the following plan. Boom. That way that if they come back and say to you, no, we never talked about, yes, we had it right here. This was the plan that we discussed. Provide support and follow-up actions, and consider with your patients that they might come to you and they're not fully able-bodied or English is a primary language. What if they have a disability? Have in your treatment algorithm accommodations or different venues or alternatives that you're going to use if the patient has audio or auditory or visual impairments, because they're going to obviously need maybe a little bit more support. Non-English speaking patients, if the English is not their native tongue, figure out how to incorporate translation. And I know I don't have to tell all of you this, but it's not appropriate to have the family member be the one to do the translating. They can translate what road we live on, those kinds of things, the spelling of a name or what have you. But think of this, you certainly don't want the abusive partner to be the one doing the translating and telling you that the patient feels safe at home, right? So make sure that you have appropriate translation. There are translation services that you can use online and by telephone. And a lot of states right now are making a push to have accredited or certified translators so that we make sure that those people are actually competent at what they do. Not everyone who is bilingual can translate medical terminology. And then consider technology and explore whether that platform supports or offers captions for patients who need to see verbal or written instructions and discussion. So privacy, we talked a little bit about that a little bit ago. Consider using standard script. We all go in to see the doctor or the nurse and they say, hi, my name is, and they're washing their hands, right? And they say, hey, and I'm going to wash my hands and we're going to sit and talk about blah, blah, blah. Consider using some kind of standard script. Hi, my name is Dr. Harris. I'm going to shut my door to ensure your privacy. Let's talk about blah, blah, blah. And so we have found when we look at studies that people have more of an impact. Yes, I do remember actually they closed the door and then we were keeping it private. Every time you can mentally check the square to let them know that you are being patient-centered and that you are doing everything to advocate for them, the better off you're going to be. So you may have heard, there's a recent study that's kind of bouncing around the internet right now that found that of about 550 cases, I think this researcher studied, they implied that telehealth and telemedicine providers seem to be kind of immune to medical malpractice claims. Do not believe that hype for 1 second. All the brokers that I've talked to say that it's bubbling up and it's kind of the new thing, and plaintiffs' attorneys are chasing that ambulance around all over the place. The shortcomings of that study, if you've ever looked at that, it didn't include non-reported cases that are currently in litigation, ones that are in arbitrations, one that are out-of-state settlements. And just kind of as a side note, only about a quarter of cases go to trial. I don't know if anybody was aware of that, but when I was working as the claims director, probably 3/4 of them, they either fizzled out, we had to pay out before they even left the hospital, we settled, we we mediated or what have you. So only when you see those cases go up in front of the court, understand that there's at least 75% or 3 times more cases sitting out there bubbling up, and they're trying to dispose of them on some level. So wanted to bring up one interesting case from 2018 that talks about telehealth and going cross country or cross state. It's Frazier versus University of Mississippi, and it involved this little girl from Mississippi, cute little thing. And she had a malformation, and she needed to go to New Orleans to see a pediatric neurosurgeon. The surgeon did the surgery. The little girl returned home with her parents in Mississippi. She started getting home care. She developed some complications, and her home health nurse called the peds neurosurgeon. He directed care. He communicated it electronically with the providers in Mississippi, and the patient wound up suffering permanent brain damage. She required tube feedings, in-home nursing care for like 16 hours a day. It was really bad sequelae. So her parents filed a suit against a slew of providers, alleging various forms of liability theories. The federal court permitted the parents to pursue a claim based on allegations that, get this, the nurse in Mississippi was not permitted to administer the medications that were issued by a provider that wasn't licensed in Mississippi. And in this case, this was a Louisiana licensed neurosurgeon, right? So he didn't have a license in Mississippi. The court said the state's Nurse Practice Act specifically defined various acts, including aiding and abetting somebody not licensed in Mississippi in performing activities that required a professional license. And so they dinged her license for unprofessional conduct, and that was a violation of the Nurse Practice Act. And then they had a negligence per se claim. They allowed for a claim of corporate negligence against the corporate offices of the home care agency. And so they argued that Mississippi regulations required that the home health agency had some kind of a governing body, some kind of an oversight in order that that something like this could be prevented. So understand that it's real, it's out there, and just make sure that you're looking at it. I highly, highly recommend doing failure modes and an effectiveness analysis if you are going to be starting to do a telehealth program. And if you already have a telehealth program and you've identified some glitches, to do a full-fledged root cause analysis so that you can identify areas to shore up treatment. So I am offering free review to all attendees for any existing policies that you have. I can give you my colleagues' information. I have a free telehealth checklist. If you want to email me, I can send that to you guys, as well as a rollout. We are going to be providing, the Healthcare Advisory Institute is going to be providing an interdisciplinary telehealth certification, and we're going to be seeking accreditation for that here within the next few months. So thank you. Anybody have any questions? I know I talked a mile a minute.
No, you covered a lot of ground, Cheryl, and I really appreciate it. And every time you do a presentation for us, it always scares me to death because you give these real world scenarios that who would have even thought, like that nurse that got hemmed up in that situation. So I really, really appreciate that. We've got some requests for the telehealth checklist, so that are coming in. So we'll get you a list of that. And then what I'm going to do, if it's okay, is I just want to talk to you about some of the safety features in IkeNotes that are going to help you with liability. And I'm going to go ahead and share my screen, if that's okay. I'm also going to be giving you a sneak peek of the new IkeNotes program. Very few people have seen this, only a handful of people. To show you what's important is to show you the actual telehealth services that we provide, and not only in the legacy program, but also in Odyssey program. So are you folks able to see my screen?
It looks like it's loading.
Okay, so it's gonna go ahead and, all right. So what you're looking at now is really known for is our content, and I'll go through and demonstrate that. But our content in IkeNotes, it's clear, it's professional, it's concise, and we also have a lot of safety features in IkeNotes that will help you. And one of those is our calendar. So you can pull a report of patients that don't have any future appointments, and sometimes clients can fall through the cracks, and you want to reel them back in. That can be done with a simple phone call or text. But if you're not able to identify who those patients are, that can be detrimental. One thing that you talked about was referrals. You mentioned that several times. So we have a referral log for all referrals, and that's housed directly in the client's chart for easy access. And one of the things that's important is having a platform where telehealth is embedded in the program. And that's essential as far as you spoke about audit logs. Those are concerned. It makes it easier to chart if you're a clinician who likes to chart while you're speaking with your clients. And also you want to make sure that you're not overpaying for telehealth. So with IkeNotes, our telehealth is $10 a month, which is a lot cheaper than some of those big name video audio conferences. I have Zoom and GoToMeeting, so I know how much we pay for those. So, but again, I'm giving you a sneak peek of the program. The new program, it's very easy to enable telehealth. You just literally click the button and telehealth gets enabled. When I go to the home area, this is what the new IkeNotes kind of looks like. You have your calendar there, so you can see exactly what you've done. I can go into my chart room, look at my charts. So I can go in and look at all my active charts. I can search here and look for my chart. So here's Piper Chapman. And in the chart face itself, I can create notes very easily. I can call my notes whatever I would like to call them. So we have case management, group therapy, we have treatment plans. This is just a regular progress note that I could go through and talk about depression and if it's present and if it continues. I'm going to say that Piper's doing, if you've ever seen Piper Chapman and the show Orange is the New Black, I am going to say that she's doing a lot worse. And the frequency is that it's chronic. And then I can go in and talk about her symptoms. I can say that that symptom is the same, and if it's present, and if she's having irritability and sadness, and if things are worse or better, I can definitely talk about that. I can go into behaviors and talk about that. Maybe she stopped her medication, her self-care is really reduced. Socialization due to COVID is very isolated at this point. Substance use is more than advised. Anger impulses. I can talk about all of those things. And then I can do therapy, like verbal content. How's she feeling? She's having some feelings of hopelessness and sadness. And what are those problems related to? We can say it's interpersonal and it is relationship. And we'll throw some sexual dysfunction in there as well. So I can go in and document all those things, what we did for her as far as improving problem solving and communication skills and coping skills and interventions. And so I just have a really good note where we've talked about things that we've done. I can do an MSC if it's normal. I can click that in. I can talk about level of care, like why we still need outpatient, maybe affect our relationship. We need continued treatment. I can do risk assessments in here. And then I can compile and sign the note. And then there's my note. So again, content is kind of what we're known for in IkeNotes, is creating that really clear type of content. But one of the things that I wanted to show you is that from Piper's chart, I can actually initiate the telehealth session right here. So I can start telehealth. Now, right now, everybody is a lot of people are not seeing folks in person. This is a good and a bad thing because, not necessarily a bad thing, because everyone that I talk to, their no-show rate is about 95%. I dealt with a really big group yesterday. They have over 20 clinicians, and their no-show rate for that group via telehealth is 95, or excuse me, their show rate is 95%. So, which is much better than when people are coming into your office. And so the telehealth session, again, you can start it right from here. But one thing, if you get those patients or clients that now they're not filling out information in your office anymore, you've got to get information to them. And we have the communication tab where I can just simply send documentation to them. I can literally come in, if it's a new patient, send some consents. I can go in, and Piper's depressed, so I'm going to send her a PHQ-9. And I'm going to send her a Zung anxiety, and I'll go ahead and just send those selected. It sends those out to her, and it lets me know that when that was sent. And then when she fills it out, I get an alert, a notification here that she's filled it out. So that's one of the really nice things is I can completely do consents. I can figure out what's going on with my patient directly from here. Another really nice thing as we're talking about consents, when I go in and if I make an appointment and I click this telehealth session button right here, it is going to enable an encrypted confirmation and send a telehealth consent. So the client can already do this in addition to the other consents that we were talking about. So that's just a benefit of kind of the telehealth. So now I have a lot of people saying, when is this going to be available? We're planning on rolling this out for commercial. It's already in beta, but we're planning on rolling this out for commercial in late fall. We want to make sure it's 100% perfect for everybody. So, but definitely the look and feel is a little bit different. It has all the functionality though. One of the great things. So. All right. Well, thank you, Cheryl. I appreciate you so much. Again, you did a wonderful job. Again, always scares me a little bit, but it gives us really good information about what we need to do to protect ourselves because everybody is kind of a lot of people are having to practice defensive medicine in today's climate. So, and that's why folks like you are so important. So wonderfully important. So,
well, I appreciate the telehealth platform that you have there because the Office of Inspector General is doing a bunch of robust audits on a lot of that, and I see that a lot of the pull-down menu that you're doing is going right alongside what their checklist is for. So I'm glad to see that you're tailoring it on your end to what's going to defend us from having a bad audit outcome. Nice job.
Well, thank you. Thank you so much. Thank you. Thank you. All right. Well, we got some other questions. Does the patient have access to computer? It has to do by phone. You can do, Sally, you can do either. The patient, even our current program, you can do it by phone or you can do it by computer. And you can pick whether to send a text message to the patient or to send them an email. So I hope that's helpful. And they don't have to download anything. There, as I mentioned before, we don't have an app. We don't have an app for the specific purpose. If we put an app out there, that opens up access to too many people. So if you're not an IkeNotes customer, we don't want you having access to that. So apps are a really good way of getting hacked. So just to kind of throw that out there. So it's all within the very secure system of IkeNotes. So again, thank you, folks. I want to be cognizant of everybody's time. Thank you so much, and y'all have a wonderful day.
Thank you.